Dear doctors, today we will be talking about cardiac arrhythmias. You know, this topic is very important, and all your life you will keep on getting the patients who have different type of cardiac rhythm problems. When we will talk about cardiac arrhythmias, in the topic of cardiac arrhythmias, we will discuss number one, what is normal cardiac rhythm? What is normal cardiac rhythm? Number two, how we define cardiac arrhythmias. Number three, what are the mechanisms? What are the mechanisms of cardiac arrhythmias? Mechanisms. And of course, then we will talk about that what are the types of cardiac arrhythmias and what is the relationship with ECG. Right? Again, let me repeat what we are going to discuss today. Number one, what is normal cardiac rhythm? Number two, what is abnormal cardiac rhythm? Number three, what are the mechanisms which produce cardiac arrhythmias? What are the types of cardiac arrhythmias? And what is the relationship of abnormal cardiac rhythm with ECG? Right? So first of all, we will talk about what is normal cardiac rhythm. You may be thinking, why it is so important to know the normal cardiac rhythm? Answer is that cardiac arrhythmias are defined as when heart deviates from the normal rhythm. What are cardiac arrhythmias? Cardiac arrhythmias are said to be present whenever heart deviates from or goes out of the normal rhythm. So first of all, we should be able to define very, very clearly what is normal cardiac rhythm. Now, let me discuss with you what are the different criteria of normal cardiac rhythm. All of you must be knowing that for normal cardiac rhythm, one of the very important criteria is that heart rate should be somewhere between 60 and 100 beats per minute, right? So let's suppose on this scale, we drive the heart rate. Here it is 60 beats per minute, and here it is 100 beats per minute, and 60 beats per minute. Now, normal cardiac rhythm is having number one criteria, that heart rate has to be between 60 and 100. If heart rate is less than 60 or more than 100, we say heart has gone out of rhythm, right? So criteria number one, heart rate between 60 to 100 beats per minute. But then there is one more requirement for the cardiac rhythm to be normal. And second requirement is that not only heart rate should be between 60 and 100, there is another important requirement that every heartbeat should be originating from SA node. If every heartbeat should be originating from SA node, it means that is the second criteria, that every heartbeat should be origin should be from, yes, origin should be from, yes, very good, SA node. If, for example, some impulses are not taking origin from SA node, they are taking origin from atria or from the ventricle or from the AV node, then these are not considered as normal cardiac rhythm. Number three criteria is that all electrical impulses or cardiac impulses should not only take origin from SA node but should also pass through normal conduction pathway, right? So we can say that cardiac impulse should propagate through, yes, cardiac impulse should propagate through normal conduction pathway, right? Again, let's discuss first three criteria. If I have to declare your heart rate is normal, it means number one, your heart rate should be between 60 to 100. Number two criteria, every impulse should be originating from SA node, right? Let's suppose here is the heart. Yes, this is the atria and here are the ventricles. Here is SA node, which is the normal pacemaker of the heart. Here is AV node, which is an excitable tissue which acts as an electrical connection between the atrium and the ventricle. And after that, current passes through bundle of hairs and bundle branches. Now listen. That second criteria is what? That this is SA node. So every impulse should take origin from SA node. Third criteria is what? That current should pass, once it has originated from SA node, it should pass through normal conduction pathway. What is normal conduction pathway? That from SA node, it should spread to the atria. From the atrium, depolarization should come to the AV node. Then from the AV node, it should come to the bundle of hairs, and then current should pass through bundle branches, and eventually through the Purkinje system, current should go to the final fibers which terminate, which supply the myocardial cells, ventricular myocardial cells. So, if your heart rate originates from SA node, passes through atria, through AV node, through bundle of hairs, bundle branches, and Purkinje fibers, that is the normal pathway of conduction, then we say your rhythm is normal. And one more criteria which is there is that while cardiac impulse should pass through the normal pathway, it should also pass through the normal pathway with normal velocities. For example, a normal cardiac impulse should move with moderate speed through atrium, should be very, very slow in AV node, and normal cardiac impulse velocity should become very fast when it is passing through Purkinje system, right?
Yeah.
So, what I really mean that not only cardiac impulse should go through normal pathway, but it should pass through normal pathways with normal velocities, velocity, right? What I mean by normal velocity, that in atrium, cardiac impulse should be with moderate speed, 1 meter per second. AV node, cardiac impulse should be very, very slow. And in bundle of hairs, bundle branches, and Purkinje fibers, cardiac impulses should become very fast, right? So these are the basic criteria which are required to declare any person's heart rate and rhythm as normal. So it is just like a 5-pointed star. You can get a star for normal rhythm, which has how many points? 5 points. Point number 1, rate is between 60 to 100. Point number 2 is every beat is of sinus origin. Point number 3 is that there should be normal, yes, normal conduction pathway, right? And then next point, point number 4 is, yes, it passes through normal pathway with normal velocity. And point number 5 is just for a tail. Is that right? So these are the basic points. If these are met with, your cardiac rhythm is normal. And due to any reason, at any point, if your heart deviates from this thing, we say there is cardiac arrhythmia is present. Heart has lost the normal rhythm. Again, if heart rate goes less than 60 or more than 100, it is cardiac arrhythmia. If origin of impulses is other than sinus, it is cardiac arrhythmia. If conduction is not through normal pathway, it is cardiac arrhythmia. And if velocity through the cardiac pathways, cardiac impulse velocity through the normal pathway is abnormal, again it is cardiac arrhythmia, right? Now I will introduce few more terms related with the cardiac arrhythmias. Number one, if the rate become less than 60, the conditions are called bradyarrhythmias. Bradyarrhythmias.
Is to say bradycardia?
Yeah, bradycardias. Many people call it bradycardias, or we simply say these are arrhythmias in which heart is having slow rhythms. So when there are slow rhythms, we call them bradyarrhythmias. And when heart rate is more than 100, right, whatever type of arrhythmia is there, as a group, that arrhythmia is called, yes, tachyarrhythmias. So one way to classify the arrhythmias of the heart is that the slow abnormal rhythm and the fast abnormal rhythms. And slow abnormal rhythms are called bradyarrhythmias, and fast abnormal rhythms are called tachyarrhythmias. Now, about the tachyarrhythmias, again there is a simple classification. If tachyarrhythmias are between 100 to 150, if tachyarrhythmias are somewhere between 100 to 150 beats per minute, we call it simple cardiac tachyarrhythmias, simple tachyarrhythmias. And if heart rate is somewhere between 150 to 250, electrical activity in the heart has gone somewhere between 150 to 250, we call this condition, usually this condition suddenly appears and then disappears. Due to this reason, because such arrhythmias suddenly start and usually suddenly terminate, we call them paroxysmal tachyarrhythmias. And then if electrical activity in the heart becomes faster and it's somewhere between 250 to, yes, 350 activities per minute, these conditions are called flutters. Of course, if such electrical activity is present in atrium, then it will be called atrial flutter. And if such activity is present in ventricle, we call it ventricular flutter. If someone is so unfortunate that electrical activity in the heart or some part of the heart goes above 350 times per minute, right, then we say patient is having fibrillation. Patient is having fibrillations. About the fibrillation, again it's very simple. If electrical activity in the heart is more than 350 and this is happening in atrium, this will be called atrial fibrillation. Or if electrical activity in the heart is more than 350 and unfortunately if it is happening in ventricles, which are the major pumps, then we call it ventricular fibrillation. Is that right? Of course, a very dangerous medical emergency. We'll discuss this thing in detail later. Then, one thing more, that when heart rate becomes less than 60, we call them bradyarrhythmias, and if it is somewhere between 40 and 60, then these are called mild bradyarrhythmias. These are called mild bradyarrhythmias. And if it is between 20 and 40, we call it moderate bradyarrhythmias. And if some very unfortunate person, he is having heart rate less than 20, of course this must be considered as a severe, yes, bradyarrhythmias. This must be considered as severe bradyarrhythmias. Now, we have classified cardiac arrhythmias in one way as bradyarrhythmias and tachyarrhythmias. And then we classified tachyarrhythmia between 100 and 150 as simple tachyarrhythmias, and rhythms, electrical activity in the heart between 150 to 250, we called it paroxysmal tachyarrhythmias, and any activity, electrical activity, which is more than 250 but less than 350, that is called flutter. And when electrical activity in any part of the heart becomes more than 350 per minute, we call it fibrillations. So this was one way to classify cardiac arrhythmias, in which we have already discussed that if electrical activity is less than 60, these are bradyarrhythmias. If it is between 40 and 60, mild bradyarrhythmias. If it is between 20 and 40, it is moderate bradyarrhythmias. If it is less than 20, we call it severe bradyarrhythmias. Now, there is another way to classify cardiac abnormal rhythms. The second way to classify abnormal cardiac rhythm is according to the main site where the abnormal rhythms are generated. For example, rhythms which are coming from SA node, and if any abnormal rhythms which are coming from SA node, we call them sinus arrhythmias. They are called sinus arrhythmias. Sinus arrhythmias mean when abnormal rhythm is due to some problem within SA node, right? Then those abnormal rhythm which are due to abnormal activity within the atrial myocardial tissue are called atrial arrhythmias. They are called atrial arrhythmias. And of course, when there are abnormal rhythms related with AV node or related with the junction, right, junction between the atrium and the ventricle, of course that junction is AV node. If abnormal rhythms are originating from AV node, we call them junctional arrhythmias. We call them junctional arrhythmias, or we simply call them nodal arrhythmias. Other name is nodal arrhythmias. So junctional arrhythmias or nodal arrhythmias, one and the same thing. And if there is abnormal rhythm originating due to abnormality within the ventricle, we call it, yes, we call it ventricular arrhythmias. Ventricular arrhythmias, right? And sinus arrhythmias, atrial arrhythmias, and junctional arrhythmia, all of them originate above the ventricular tissue. Again, sinus arrhythmias from SA node, atrial arrhythmias from atrial tissue, junctional arrhythmias from AV nodal tissue, right? These three arrhythmias take origin above the ventricular area. Due to this reason, some people prefer to call all these three arrhythmias, they lump them together as, they lump all these three arrhythmias together as supraventricular tachyarrhythmias. Again, let me tell you what is the concept of supraventricular tachyarrhythmias. If tachyarrhythmias are of sinus origin or atrial origin or junctional origin, of course, tachyarrhythmia from any of these three places are definitely taking origin above the ventricles, right? And you know, ventricles are the real pump. They are the major pumps in the body. They are of prime importance to us to maintain the cardiac output. So we simply classify the tachyarrhythmias, and the tachyarrhythmias originating above the ventricles and tachyarrhythmias originating from the ventricles or within the ventricles, right? And tachyarrhythmias which take origin above the ventricles, they are called supraventricular tachyarrhythmias, right? And supraventricular tachyarrhythmias are all those tachyarrhythmias which are either taking origin from SA node or taking origin from atrium, or they are taking origin from junctional tissue. Is it clear? Right. Now we will be talking about the mechanisms of cardiac arrhythmias. Mechanisms of cardiac arrhythmias. basically, primarily there are three mechanisms. Number one, there may be increased automaticity. You know how do you define automaticity? Automaticity is defined as a property of any excitable tissue which can undergo depolarization spontaneously, right? And if some cardiac tissue develop high automaticity tendency, it means some cardiac tissue develop the power to produce depolarization spontaneously but very rapidly. Of course, that will start tachyarrhythmias, right? So one mechanism is increased automaticity. Second mechanism is triggered automaticity. And third mechanism is phenomenon of reentry or circus movement. I will explain all of them one by one. Circus movement. Now, first I will explain the concept of increased automaticity. Let's suppose here is a cell with SA node, and as we have discussed in previous lectures on the electrophysiology of the heart, we have already discussed that SA node work as a pacemaker because it has a tendency to undergo depolarizations spontaneously. I am drawing here the electrical activity of SA node. You know, this is the resting membrane potential of SA node. This is the threshold potential. In SA node, many cells, in SA node the cells have leaky sodium channel. So when sodium trickles into SA nodal cells, the resting membrane potential cannot really rest because the incoming sodium will take the resting membrane potential towards the threshold. As soon as resting membrane potential reaches up to threshold, what really happens that there is opening of voltage gated calcium channels, and lot of calcium comes in, and this produces calcium dependent depolarization. And of course, when depolarization is done, then there is opening of voltage dependent, yes, potassium channels, and potassium efflux, that is the loss of potassium from the cell, takes the membrane potential back to the resting level. It means membrane become again repolarized back to its normal resting membrane situation. And as you know that as soon as membrane will go to the resting level, again sodium will come in, take the resting to threshold, again calcium dependent depolarization will start, and potassium dependent repolarization will start. So and so forth, SA node undergoes spontaneous depolarizations and act as a pacemaker for the heart. Now, how this automaticity can be increased? One way is that let's suppose you stimulate the SA node with epinephrine or norepinephrine. When it stimulates its receptors on the SA node, you know these receptors are beta 1 adrenergic receptors. So when epinephrine stimulates its beta 1 adrenergic receptors, what really happens that stimulate intracellularly G stimulatory proteins, and which eventually lead to phosphorylation of some additional calcium channels, and additional calcium comes in. So we can say when epinephrine act on this automatic tissue, it load that tissue with the extra cations, or it load that tissue with the calcium, and this added calcium which comes into the cell that help the cell to move towards the resting membrane potential to move to the threshold potential more rapidly, and there is more frequent production of action potentials, and we can say that normal automaticity is enhanced or increased after the action of epinephrine on SA node, and SA node will be firing more frequently, and if SA node is firing more frequently, we say there will be sinus tachycardia. So this was one example that how increased automaticity can produce tachyarrhythmia. Now we come to another example where triggered automaticity can lead to tachyarrhythmia. Let's suppose we talk about a ventricular cell. This is a cell from the ventricle, and first I will draw the normal ventricular electrical properties. In a normal ventricular cell, here I am showing resting membrane potential, and here I am showing threshold potential, right? Now, and normally what happens that in ventricular cells, resting membrane potential keep on resting until the nearby cell throws some cation into the cell, and this cell will undergo depolarization, and it has a long plateau, right? And after that, now this is the electrical activity of ventricular cell. Here it is sodium dependent, of course, depolarization, right? And this plateau is produced when potassium is leaking out but calcium is entering into cell, right? When potassium is going out and calcium is coming in, so there is loss of potassium, gain of calcium, or loss of positive ions as well as gain of positive ions, so there is no significant change in the electrical potential of the membrane. And of course, eventually calcium stop coming in, but potassium keep on going out of the cell very rapidly, and that produces repolarization, right? After that, depolarization and eventually repolarization, membrane potential come back to the resting value. Now, sometimes ventricular arrhythmias may be produced due to a fact that from here a new action potential takes off. And if action potential takes off at a very early time, this is called early after depolarization, because this was the original depolarization, and this depolarization has started after this triggered depolarization has started after the spontaneous depolarization, but this has started at a very early time, so we call it early after depolarization. And sometimes what happens that resting membrane potential is fluctuating, and if it touches the threshold, a depolarization is produced, but this depolarization is not so early, so it is called delayed after depolarization. Delayed after depolarization. So let me tell you, number one, when there is triggered automaticity, we are talking about triggered automaticity. When there is triggered automaticity, then what really happens after the spontaneous depolarization, there is triggered depolarization. Now this triggered depolarization may be early or triggered depolarization may be late. If triggered depolarization is early, we call it early after depolarization. And if it is delayed, we call it delayed after depolarization. So whenever membrane properties are abnormal and they are producing early after depolarizations or they are producing delayed after depolarization, again tachyarrhythmias are produced, and such tachyarrhythmias are called triggered automaticity induced tachyarrhythmias. Again, what are the examples of, what are the mechanisms which can produce suppose delayed after depolarization? Again, if these cells become ischemic, if myocardial cells become ischemic, or these cells become injured, the membranes become injured, or due to any reason these cells load lot of cations, for example catecholamines. Catecholamine can lead to loading of cations. So when a lot of cations are loaded, resting membrane potential cannot rest, Either the membrane has ischemic injury or it has any type of injury, for example by inflammatory products, or catecholamine is stimulating the membrane. Under all these circumstances, membranes of the ventricular cells are loading cations into the ventricular cell. When more and more cations are loaded, then resting membrane potential cannot really rest, and cationic load will produce fluctuations in resting membrane potential, and if such fluctuating resting membrane potential touches the threshold, it may produce unwanted triggered automatic events, and that may precipitate tachyarrhythmia. The third mechanism of tachyarrhythmia is reentry or circus movement. Now let me explain how reentry can produce the problem. Let's suppose this is a piece of myocardium, right? This is a piece of myocardium, and let's suppose there is some area which is electrically not excitable. For example, this is a scar in myocardium, right? And it is electrically not excitable. Now listen carefully. If an electrical stimulus comes and it starts moving around this electrically resistant area, right? When it will move around, if they meet each other at the same time, then they cannot re-enter, they have to move forward. So in this particular example, we see that electrical impulse has approached an scarred area in the heart, and it went around that from the both sides, but because conduction velocity on both sides was same, so impulse reaches to other side of the area at the same time, and these impulses cannot re-enter into each other area because every area is refractory, and this impulse has to move forward. Now, if suppose we take another example, this is another area in the heart and it is having scar, and electrical current comes to this area. On one side it moves well, and from other side it cannot move. There is a block, right? Now, the limb, the side on which it moves slowly, when it will come back, it will find this area excitable, and if this point comes out and finds this area excitable, then this current will enter into the area back, and then this current may start moving around this dead area, and this type of situation is especially seen when total time taken by a cardiac impulse around an area is longer than the time required for a blocked area to recover from the refractory phase and become excitable. Again, let me tell you that if cardiac impulse moves around a dead area or electrically dead area, then when impulse is moving around the dead area and total time taken to move in the circle is longer than the time for any block in the tissue to come out of the refractory area, then it will start moving rapidly. And if this start moving around that area rapidly, this is called circus movement. It will keep on throwing cardiac impulses with every circle to the rest of the heart, and tachyarrhythmias will be generated. This is one of the mechanisms how tachyarrhythmias are generated in patients with ischemic heart disease. Again, let me recap how the tachyarrhythmias can be produced. Tachyarrhythmias can be produced when normal automaticity is enhanced, like catecholamine stimulates SC node. Or tachyarrhythmia can be produced when triggered automaticity is there. For example, ischemic cells in the ventricular area and ischemic cells have loaded lot of cations, and then their resting membrane potential become very near to the threshold, and anytime they can produce triggered depolarizations. Then another mechanism is when in the myocardium there is some area through which current cannot conduct, and current moves around that area, and if there is a long time for the current to move around that area, right, and during this time that every point is excitable, so circus movement will start and there will be excessive electrical stimulation of the heart. Now we will talk in detail sinus arrhythmia and ECG patterns, right? We'll talk about the sinus problems, sinus arrhythmias and ECG patterns. Sinus arrhythmias and ECG pattern. First of all, we will talk about physiological sinus arrhythmia. Physiological sinus arrhythmia. Physiological sinus arrhythmia is a normal phenomenon which happens with all the people with normal heart and normal neurological connections. What really happens, as you know, that heart is under the influence of autonomic nervous system, right? And one of the major parasympathetic outflow, which is called vagus, that controls the automaticity of SA node. From the medulla, this is the vagal outflow, and vagus stimulates the activity of, more accurately, vagus influences the activity of the SA node as well as AV node. Right now we'll concentrate the relationship between the vagus and SA node. Vagus is stimulating the final neurons which release acetylcholine on the SA node. So vagus has inhibitory influence on SA node. It means whenever vagus is stimulated, right, SA node will be inhibited and heart rate will go down. And whenever vagus is itself inhibited, when vagus is not working, heart rate will go up. Now, a very important concept to understand is that vagal activity fluctuate during respiratory cycle. During expiration, suppose here is inspiration and here is expiration. During inspiratory phase, vagus is inhibited. It means during inspiration, if vagus is inhibited, it means heart is released from vagal inhibitory action and heart rate will go up. But during expiration, vagus is stimulated. Because during expiration, vagal outflow is stimulated, so it means during expiration, through the vagus, SA node will be inhibited. So what does it mean? That during inspiration, your heart rate will go slightly up, and during expiration, your heart rate will go slightly down, right? And this is normal and physiological. So we can recap all this information that during respiratory cycle, vagal outflow alters. And when vagal outflow alters, then SA node automaticity alters, and that changes the heart rate. During inspiration, vagus is inhibited. Once vagus is inhibited, then vagus cannot inhibit SA node and heart rate goes up. So this is a slight increase in heart rate during inspiration. But as soon as you start expiration, vagus is stimulated, it is able to inhibit the heart rate. So during expiration, your heart rate goes slightly down. This phenomenon is called physiological sinus arrhythmia, right? And here's a small clinical point that patient who have autonomic neuropathy, for example, the people with diabetes mellitus, if vagus is not working, right, what will happen? That their heart rate will not fluctuate with the inspiratory and expiratory system. Again, let me repeat it, that due to any reason, if vagus is unable to influence the heart, for example, in diabetic patient, if there is autonomic neuropathy, and during the autonomic neuropathy, if vagus is not functional, one of the complications will be that heart rate will not fluctuate during the respiratory cycle, right? In the same way, one more piece of information is that during the heart plant, patient who has transplanted heart, right? Transplanted heart is a denervated heart and it is not connected with the vagus. So transplanted heart is not under vagal influence. And if transplanted heart is not under vagal influence, it means that transplanted heart will not undergo physiological sinus arrhythmia, right? The heart rate of a patient having a transplanted heart will remain same during the respiratory cycle, right? Now, let's draw the ECG of physiological sinus arrhythmia. Let's suppose first I draw the ECG, P wave, QRST, P wave, QRST. Of course, again next cycle P wave, QRST, P wave, QRST, P wave, QRST. Now I have drawn some patterns over here. What I really want to tell you that during inspiration, this distance, this is R wave, this is also R wave, and this distance is called R to R distance. Now, during inspiration heart rate goes up. It means during inspiration R to R distance will decrease. In a given time, there will be more P waves and more QRS complexes. It means that during inspiration in a normal person's heart, if you look at the ECG recorded during inspiratory event, R to R distance will decrease. In a smaller time, there will be more complexes. But during expiration, when vagal influence becomes more and heart rate goes down, so during expiration, R to R distance will become more, right? So again, if you look at the ECG and R to R distance regularly becomes shorter, right? That must be during the inspiration, and it becomes regularly slightly increased, that will become expiratory system, right? After this, physiological sinus arrhythmia, now we'll talk about one more event. Let's suppose we talk about sinus tachycardia. Sinus tachycardia. What is meant by sinus tachycardia? First of all, you must know what is meant by tachycardia. We have already discussed tachycardia means heart rate is more than 100. When we say patient has sinus tachycardia, it means that heart rate which is more than 100 is due to increased activity in the sinus, increased activity in the SA node, right? Sinus tachycardia very commonly seen during exercise. Exercise increases your heart rate, or patient with fever, or patient with thyrotoxicosis, right? And there are many other conditions which increase the heart rate. And in these conditions, like exercise or fever or thyrotoxicosis, there is overstimulation of SA node. And when stimulation of SA node is there, excessive stimulation to SA node will generate depolarizations more frequently and your heart rate will go up. Under these circumstances, what will happen? Look, this was the normal. Now, these were the P waves, and of course these P waves are presenting atrial depolarization, which is of course occurring due to sinus activity. Now, if there is sinus tachycardia, what will really happen that SA node will be firing more frequently. It means that P waves will be produced more frequently in a given time. So what will happen? Look at the ECG of sinus tachycardia. Now P wave appears earlier, and if P waves appears earlier, then again P waves appears earlier. So due to increased activity of SA node, right, what is happening? Now you can see in the same given time the heart rate has been increased. As you can see it that here when the heart rate was normal, and in this given time there were 1, 2, 3, 4, 5, 6 sinus activities. But if you look at this situation where there is sinus tachycardia, we find 1, 2, 3, 4, 5, 6, 7, 8 and 9 P waves, of course followed by the QRST complexes. So what really we see that in this black pattern we find the normal sinus activity, right? And in this red pattern we find that there is sinus tachycardia because P waves are appearing earlier in the time, SC node is firing at a faster pace. So in a same given time, in this particular case, we have more cardiac stimulations. So heart rate increases. Now we can take another example that let's suppose there is another patient who has sinus bradycardia. Who has sinus bradycardia. It means this patient has slow heart rate. Bradycardia means slow heart rate. But the origin of slowness is problem with the sinus, problem with the SC node, that there is something which is inhibiting the SC node, so heart rate is less than 60 per minute, right? Classical example may be, yes, athletes. You know why some athletes, their heart rate is very slow, right? The reason being that they have increased vagal tone, right? Then we can talk about patients with hypothyroidism. When you have hypothyroidism, then your heart rate becomes slow. Or patient with hypothermia, right? Their heart rate becomes slow. Or patient with obstructive jaundice, cholestatic jaundice. In these cases, retained bile acid accumulate in SC node and slow down the activity of SC node. So whatever the reason, if there is anything which is pathologically slowing the SC node automaticity, then naturally when you look at the ECG pattern, you will be able to find the evidence of bradycardia. Let's suppose in this particular case where there is sinus bradycardia, ECG pattern will be, let me show it by blue, that P waves are appearing less frequently. So here's a long pause, then there is P followed by QRS T. Then again there's a long pause, then there's P wave and QRS T. Again there's a long pause, P wave followed by QRS T. Now what we really see that here P waves are appearing with lesser frequency in the same given time in which normal person was producing 6 P waves, person with tachycardia during the same time was producing how many P waves? 9 P waves, and this person during the same time is producing just 4 or at the maximum maybe 5th wave. So what we really see that in case of sinus tachycardia, RR distance will become less, but in case of sinus bradycardia, RR distance will become more. Or again, but remember, when we talk about sinus tachycardia or sinus bradycardia, the electrical activity which is increased or decreased, that is originating from sinus tissue, right? Then we will come to one more condition. In that condition, there is SC node is injured and it behaves in an irregular fashion. Suddenly sinus activity become increased and then sinus activity become slower than normal. If it is happening like this, that you have a disease and SC node is infarcted partially or injured partially, and suddenly it becomes fast, and then it becomes suddenly slow. So we can say you have a funny type of syndrome which is called Tachycardia syndrome. That is sinus syndrome, sinus Tachycardia syndrome. Or an easier way to remember this is that sick sinus syndrome, S-I-C-K, sick sinus syndrome. So in the sick sinus syndrome, what really happens that SI node is behaving in a pathological fashion. For some time it may be firing faster than the normal, and at other times it may be firing slower than normal pace. For example, that in Tachycardia syndrome, maybe SI node is first firing more frequently and P waves are appearing very early in the time, and then SI node suddenly start firing at a slower pace. So then of course heart rate for that very piece of time will be less than normal. So we can say this is a patient, he is having Tachycardia syndrome, or simply we can call this patient has sick sinus syndrome. Again, let's recap. We were now concentrating on sinus arrhythmias. But whenever we talk about sinus arrhythmias, we must remember that even a normal person has physiological sinus arrhythmia, which is very mild, and this physiological sinus arrhythmia is due to vagal tone fluctuations during respiratory cycle. Then there is sinus tachycardia, in which SI node overdrives the heart. Then there is sinus bradycardia, where SI node is underdriving the heart. Then there is sick sinus syndrome, where SI node sometimes overdrives the heart and then underdrives the heart. Now we will be discussing atrial abnormal rhythms and ECG. Atrial tachyarrhythmias, and ECG. Now when we talk about the atrial tachyarrhythmias, basically there are three types. There is atrial tachycardia, atrial tachycardias, atrial flutters, and atrial fibrillation. Now, in atrial tachycardia, what really happens that P waves or atrial activity is, atria is acting as pacemaker, and it is producing electrical activity at the rate of somewhere between 120 to 250. So atrial tachycardia, the electrical activity rate is somewhere between 120 to 250 per minute. In atrial flutter, the electrical activity is somewhere between 250 to 350. And we have already discussed that in atrial fibrillation, electrical activity in the atria is more than, it is more than 350. Now, when you look at the ECG pattern, all these things are produced when atria is abnormally irritated or there is re-entry phenomenon. Now, if you look at the ECG pattern, what really happens in atrial tachycardias, you can see some P waves, but you find well-defined multiple P waves, right? And after those P waves, you may find QRST complex. It means if there were 3 P waves, right, but only one could be conducted down the AV node, and it was able to produce depolarization of ventricle and eventually repolarization. Then again you find multiple P waves, and they may be followed again by one QRST, and this pattern may be repeated many times like this. So what we really see that atrial rate is where atrial electrical activity is very fast as compared to the ventricular electrical activity. Again, you know, these P waves which are well defined, but they're multiple, so multiple P waves are followed by QRST complex. So it means the multiple atrial activity which is followed by one, yes, ventricular electrical activity, right? Now, in case of atrial flutters, what really happens that electrical activity in the atrium become really very fast in case of atrial flutter. So in this case, what you really see are special type of waves, and they are not well recognized P waves, right? And then there may be QRST complex, and after that again sawtooth like P waves, and followed by, they should not be really called P waves, they are called actually flutter waves, so we call them F waves. So flutter waves are a sawtooth like shaped, you can say, pattern drawn by the very rapid depolarizations present in the atrial tissue, right? And then again this is followed by QRST. So these are flutter waves, right? Now these are flutter waves. But when we talk about atrial fibrillation, it means there's a very fast rhythm in the atrium, right? And in this particular case, when we say that there's flutter, there's fibrillation, it means there's more than one ectopic foci, they are simultaneously firing, and due to so many irritable foci which are trying to take control of the atrial activity, simultaneously there may be multiple vectors present in the depolarization vector present in atrium, and these vectors are directed in different directions at a given time, and so these vectors are very small, and these electrical activity which are from multiple sources, and they are producing small vectors which are directed against each other. They are not synchronized, these are dissynchronized. So due to that reason there is no well-defined electrical power in the, or well-defined electrical vector in the atrial area. Due to that reason, now you will find that baseline which should show P waves, right? This baseline just shows some fluctuations, and these fluctuations are showing that there are small electrical activities, but many of them present in atrium. Then eventually one electrical activity will be conducted down through AV node, and that will produce QRST complex. But again there may be slight fluctuation at the baseline, and then again QRST will be there, right? And this pattern will be repeated again and again, right? So this type of ECG is typically seen when there is atrial fibrillation, and these small waves are called F wave. But remember, flutter F waves are shown by the capital letter, and fibrillation F waves are shown by the small letter. Now again let me repeat it. When there is abnormal electrical activity in the atrium, it may lead to atrial tachycardia, or it may lead to atrial flutters or atrial fibrillation. In this case, electrical activity in the atrium is progressively increasing. In case of atrial tachycardia, there are multiple well-defined recognizable P waves followed by QRST complex, right? In case of atrial flutter, there are not well-defined P waves, rather we see that there are sawtooth-like baseline fluctuations, and we call them flutter waves, right? And in case of atrial fibrillation, the fibrillation waves are multiple, very small. They must show slight oscillation in the baseline and occasionally punctuated by QRST complexes. Again, one point which is very important is when a patient is suffering with atrial tachyarrhythmia, we have to be very careful that these tachyarrhythmias should not transmit rapidly to the ventricles, because if atrial tachyarrhythmia rapidly transfer to the ventricle, then they can precipitate ventricular tachyarrhythmias, which may be life-threatening. Dangerous aspect related with the atrial tachyarrhythmia is that if AV node is highly excitable, it takes too many impulses from the atria to the ventricles. And if AV node is conducting too many impulses, electrical impulses from the atria to the ventricles, that may overdrive the ventricles, and under these circumstances, atrial tachyarrhythmias may precipitate ventricular tachyarrhythmias, which may be life-threatening, right? So, what we really do in the management of these patients, ideally speaking, we must terminate the atrial tachyarrhythmias. But if we cannot terminate the atrial tachyarrhythmias, then we should slow down the AV node, because if we slow down the AV node in these patients, even if fast electrical activity continues in the upper story, but if AV node is really slow, it will allow lesser impulses and controlled transfer of cardiac impulses from the atrium to the ventricle, and we will not have the risk of precipitation of ventricular tachyarrhythmias. I think all of you must be knowing the drugs which are commonly used to slow down the AV node, right? These drugs which slow down the AV node, of course, they are calcium channel blockers, they are beta blockers, calcium channel blockers like verapamil, beta blockers like propranolol, or these drugs may be digitalis. You know, digitalis everyone knows that digitalis is positive inotropic drug and which is used in cardiac failure, but very good doctors know that digitalis can also increase the vagal activity. It's a vagotonic drug, and when vagal activity is increased, AV node is slowed down, so too much impulses from the atrial area cannot go down into ventricular area, right? So digitalis here is used as a vagotonic drug. Then sometimes to really slow down the AV node for a very short